Welcome to the Doctors Making a Difference podcast, where we help physicians to be empowered with the tools they need to be successful in medicine, in finance, and in life. Join us as we highlight doctors and other professionals around the world who are making a difference. Today, you get to meet one of my great friends, Dr. Lance Hansen. I think you'll really enjoy this episode. You'll get an insight of what it really is to practice rural medicine in Idaho in 2026. Maybe some of you have wondered, what would it be like if I had kept all the skills I had in medical school? Or what would it be like if I was that small town doctor that I read about, or maybe someone like that took care of me when I was a kid? Or maybe you're a resident or a student or even a pre-med student who's saying, I want to be that kind of doctor that can do all these different things. It still exists, and I'm excited to present this episode with Dr. Lance Hansen. In this episode, you'll hear me talk a little bit about some changes that I need to make in my own practice related to my health, and it's a little bit hard to share that information, but I think it's important to share the journey, and I appreciate all the support and kindness that you, all my listeners, have shown to me, and I look forward to presenting this. I'm pleased today to welcome my friend, Dr. Lance Hansen. In this case, I have the privilege of knowing the guest for a lot of years. Dr. Hansen and I worked side by side for a decade. I used to joke that I would see him more than my wife sometimes because we'd go through some of those busy weeks, and it just built a friendship and a camaraderie over that kind of a work. But anyway, Lance, would you mind introducing yourself to our audience?
Sure. Thanks, Peter, for having me. I appreciate the opportunity to talk with you, and I've enjoyed your podcasts. I'm Lance Hansen. I'm a full spectrum family physician practicing in Preston, Idaho now, but grew up in Southeast Idaho on a potato farm, and I went to the University of Washington School of Medicine for medical school, and then did a rural training track residency, first year in Boise, the second and third year in Caldwell, Idaho. And then, as Dr. Crane or Peter was mentioning, my first job outside of residency was almost 11 years in Bear Lake, sharing the same office with together. So it's good to be back together.
Yeah, it is. No, I agree. I've missed that time. We've learned a lot. And I think anytime you work with somebody for a long time, you gain perspective and you see how the other person does it. And then, and I guess the other thing is, I couldn't have possibly done that time without you by my side. And I don't think anybody could do rural medicine without good partners. We're going to talk a little bit about rural medicine today. And I think people have this in mind that they're going to be the only person in town. You can never leave and you can never do anything. And I think that would probably be true if it weren't having a partnership. But tell us a little bit more about your journey. Why did you choose to become a physician? And then specifically, why did you choose the somewhat insane path of being a rural doctor? I say it's insane. I can speak from personal experience.
Yeah. I think just growing up, I was really interested in the sciences. I loved AP biology in high school, and then I took the Nat and Phys for my first course in college and just really liked it. I had a friend growing up who always said he was going to be a neurosurgeon, and so it was on my mind a little bit. But I learned over time, like, what brings me satisfaction and fulfillment. And part of that I learned throughout my undergrad years was just relationships of trust that are meaningful and developed over time. And as I was learning that about myself, I saw that in family physicians that I shadowed in undergrad. So that's really what attracted me to it in the first place. As far as ending up in a rural environment, I came from a rural environment. I enjoy the culture, the values, the hard work, independence that I learned on a farm. And I wanted my kids to have a similar experience. And also I wanted my kids to grow up closer to their grandparents. So my wife and I, both from Southeast Idaho area, always wanted to come back to the area. I knew that family medicine was a great option to be able to live anywhere you want. Although I was interested in other things in medical school, family medicine, I just found a lot of meaningfulness in the challenges, rural family medicine, as well as the relationships that you develop over time that just seemed to be more substantial and meaningful than what I had experienced in bigger settings in medicine.
Yeah, on that, I can relate. I think you have the opportunity to pursue a lot of specialties. Most people I talk to that are family docs will say, I liked obstetrics and I liked pediatrics and I liked surgery and I liked in medicine. I liked hospital medicine. I like everything. And it sounds like you and I kind of had a similar interest set that way. But you're right. There is something really powerful and genuine when you're a key or integral part of a small community and you get to know the people, not just in one setting, but you see them in the community. You see them in at the grocery store or at the basketball game, or you see them in church or wherever it is, and you form these really deep bonds with people. It's challenging in some ways because you don't have a lot of privacy, but on the other hand, you would do anything for those people because you genuinely love them.
Exactly. In residency, when I was just seeing people, the World Training Track was in Caldwell, Idaho, which was a town of 35,000 people. And when I'd see patients there, it was really only in clinic most of the time. You wouldn't see them, like you said, at the basketball game or the school function or wherever it is, the grocery store. And what I found was when you see people in different settings, you actually get to know them much better. You get to know their social circumstances, their family. And as such, you see them more like that. You don't just see them as that patient that I see every 3 or 6 months or every year who has this diagnosis and that diagnosis. You see them more as a person, a family member, a friend. And I think with that becomes a deeper responsibility. And that can add a lot of stress too when you're not sure what's happening or when there's really something stressful going on. But it's really fun to just share in those triumphs and also just be there in those times of trial of someone that you really know and understand a lot more than just superficially in the clinic.
Yeah. And maybe just talk a little bit because those who are listening may not understand what you mean when you say you're a full spectrum family doctor. It's interesting as I visit with people all over the United States, primarily and other places. Most people have specialized in something. And even those who are primary care doctors, a lot of them work in environments where they're really a little bit more focused on one patient population or their one practice setting. Like I'm mostly in the clinic or I'm mostly a hospitalist in the hospital. And so describe a little bit about what a small town rural doctor in Idaho does. It's something I understand deeply because it's what I do. But maybe describe that for, especially for those who are residents or students who might be contemplating to understand what that means.
Sure. So, I mean, full spectrum, I'm taking care of everyone from birth until death. And for example, I wouldn't even call it a week because it just is ongoing and perpetual what I do. But every week I'm in clinic 4 days a week. My first patient I see a little after 8. The last patient is a little around 4:30, but then I'm of course doing paperwork and doing medication refills, answering questions, building phone calls, doing what you would see in any clinical setting. On top of that, before I even get to clinic, I've gone to the hospital. I've rounded on patients that are inpatient or swing bed rehabilitation patients. That can range from anywhere from 0 to 8 patients a day. So sometimes when I have a lot, I'm getting there early in the morning, around on most of them. Sometimes that carries over into lunch or even after clinic. Often throughout the day, you're interrupted by phone calls from nurses for those patients or texts from nurses or even patients in a small town. There's lots of patients who have your phone number and are texting you about this and that if they need to be seen. And so you're multitasking in many ways between many different environments. So that's 2 of them. But I take ER call twice a month, ER call here and there in Bear Lake. Oftentimes I was on for 24 hours at a time, but I'm still doing all my other regular duties. I'm seeing patients in clinic, but when a patient comes to the ER, sometimes, you're popping over to the ER. Sometimes you're canceling clinic because the patient's really sick. And so you're doing ER medicine. I'm on call 24/7 for my own obstetrical patients. So they contact me day or night if they need something. Obviously, they don't schedule when they're going to labor. There's a lot of disrupted sleep. And then, of course, I'm taking care of patients in the nursing home. That's usually scheduled out one morning a month. But I'm once again fielding a lot of phone calls or texts concerning their needs throughout the month. There's one morning a week where I do colonoscopies and EGDs before going to clinic. So it's just a wide variety of the patients I'm taking care of and the challenges that they're facing and that I'm encountering every day based on full spectrum family medicine, not just solely in the clinic, but taking care of them in so many other settings. And honestly, taking care of them doesn't end when I go home at night. Like I said, I'm on call 24/7 for obstetrics, but oftentimes I'm thinking about certain patients and still studying at home and still getting texts at home from patients or those.
Yeah, no, it's exhausting when you say it that way. You're like, whoa, but it is a lot. And maybe one other point to just clarify for the folks out there, you mentioned that you do obstetrics. So who does all the C-sections for you, Dr. Hansen?
I would be myself and my other 2 family physician partners. There were when I was in Bear Lake, it was you and I doing it,
Yeah.
and Dr. Campbell. So Yeah, it's so full spectrum family medicine, you're expected to do a lot of things in a lot of different specialties. You gotta get comfortable being uncomfortable, really. I remember learning how to do chest tubes on dummies, but my actual real first chest tube was on a patient I needed to do it in the ER in Bear Lake. And a lot of things don't happen that way. A lot of times we have excellent training ahead of time, but sometimes you don't get those opportunities and you just have to roll with the unknown punches that are coming your way.
Yeah, and it is crazy. Like, it sounds overwhelming in some ways when you say, "Man, I do everything in obstetrics, inpatient, outpatient, nursing home, pediatrics, and I'm available for my OB patients pretty much all the time." And I've have thought about that over the last few years here, especially. It's challenging, but the only way you can really make it work is because you have great practice partners. I remember you and I had a case a few years ago. It was a nice lady that was in the ER, and she needed a chest tube. She was short of breath. She had a pneumothorax and all sorts of stuff going on. I'd placed a pneumothorax a few times just by being in the ER, but you need a set of hands. And I think it was probably 6 or 7 PM and something was happening. And everybody was walking by and everybody was getting the supplies in the ER. And then I hear Lance Hansen's voice coming down the hall, just coming to round on somebody or check on somebody. I'm like, Lance, get in here.
Yeah.
Which was so helpful because you just need another set of hands, another set of experience, eyes to look at it and say, try this, do this, or even though you have done something quite a few times, the things that we don't do every day, especially in a more low census ER, it's important to have backup and have somebody there at your side. And I think having other doctors in rural areas that can do the same spectrum makes all the difference.
It sure does. If you don't have some good colleagues who are willing to back you up and help you out, it would be a lot more stressful, I think, and it's nice to be able to return that favor too.
Yeah. Another challenge I've observed, and you've been part of medical education, so I think you can talk about this. In my experience working with students and residents, I don't see quite as many people who are targeting a kind of a rural lifestyle like this. Or I see some who say, "Yeah, I'll do that, but I will do this part, but not that part." I don't come across very many who say, "Yeah, I want to be the person who has this broad skill set and still uses basically everything that I learned in medical school." And I'm curious what you've observed and what is a future option for rural communities that really need these full spectrum family docs that can do all these services.
Yeah, I definitely think it's been hard for rural areas to recruit and retain physicians. I do feel like there's just been a change in people's preferences over the years to more work-life balance, and that includes usually more scheduled type shift work. In the ER now, it's all shift work. You're even seeing OB hospitalists who are now covering shift work. You're not delivering your own babies. Of course, you have hospitalists who are taking care of inpatients, and so many people want to leave work at work and maintain that work-life balance. And so I think that's one reason why you're seeing that. I also think that people aren't getting as much exposure to rural medicine if they haven't come from that background. I think one thing that was beneficial for me in training was even though I was in a rural training track, I still went out to rural sites. I went to Soda Springs for a couple of weeks and to Preston, where I'm currently practicing for a couple of weeks to see what it really looks like to practice there. And so I think when you get true exposure, it helps you to better see some of the challenges, but also some of the rewards that are sometimes understated.
Yeah. So, if somebody was facing that, saying, "Okay, I've got this rural background and I want to do it," what do you suggest now? I've observed there's some rural training tracks and there are some fellowships within the specialty of family medicine in particular that are rural focused. And there's high risk obstetrics tracks that people can take. You and I, when we graduated, that wasn't really common. It seemed like that was more the exception than the rule. It seems like more people are doing those. And I wondered if do you find that those actually have helped people? Have you worked with residents or fellows that have done those kind of training? Do you think that like gives an answer for the future of rural communities?
I think it'd be part of the equation. I haven't had a lot of experience specifically with a lot of those things other than OB fellowships, but I do feel like there's a few reasons why people don't want to go to rural medicine or they don't stay in rural medicine. One being cultural, maybe the value system or the culture or the isolation geographically can be a kind of a downer for some people. But I think from a medical standpoint, people are leaving because it's long hours. It can be hard work, but also it can be scary. You're out there on an island, even though you have colleagues. A lot of times you're on an island, you don't have specialists right there. And so I think that any extra training you can get is going to help you to feel a little bit more comfortable being uncomfortable. And I think that builds confidence where you figure out that you can do it. That's something I would say to people training that are a little bit apprehensive is you can do it, but you do everything you can in residency. I think that sometimes people are pigeonhole themselves too quickly to say, oh, I'm not going to do that. I'm not going to worry about learning it that much. But I would say in residency or medical school, you learn as much as you possibly can because as we've talked about in the past, you can always narrow down your spectrum of practice, but you're never going to broaden it once you get out and start practicing.
Yeah, that's a good point because I mean, no matter what it is,
Yeah.
our brains tend to forget things if we don't do them routinely. And so I feel like that was one of the blessings of doing a broad spectrum residency and then jumping right into rural medicine for the last 15 years. I just feel like I have just never really stopped doing all that stuff. And so it's one of those things that the community needs and almost takes for granted, where you say, hey, yeah, we can get you into a doctor that can do it. Yeah, you need a colonoscopy, you need an upper endoscopy, you need someone to deliver your baby or take care of your family member. Sure, Lance Hansen can do it all. We'll get you in a couple weeks. And I think people in bigger areas maybe forget that it's not so parsed out or not broken into so many pieces. And that's both challenging for a physician and rewarding, but it's an older model of medicine. Doctors in the past seem to do that a little more, but it has become more the standard that doctors seem to find one little slice of medicine and stick with it, which I like. But I wonder, what do you think the effect is on rural communities specifically if we have doctors narrow their spectrum a little bit?
I think first of all, cost effectively, it's just not there. Like these critical access hospitals can't afford to run like a bigger hospital. They can't have full-time OB on call or hospitals on call or ER doctor on call. And that's where full spectrum family physicians really fill a void is they can do so many different things. Just because of numbers, you can't sustain having an OBGYN or you're actually going to need probably two of them in a rural community. And even then, they're going to be on call 50% of the time. You can't sustain those wages for the number of deliveries you're going to have in rural communities. And I think cost effectiveness wise, it's just not there for a critical access hospital to run like a bigger hospital. You need to have physicians who can fill multiple voids, whether that be ER and clinic or whether that be obstetrics in clinic or inpatient in clinic at minimum, that I think that's what these rural communities need is a jack of all trades and someone who can do a lot, but also knows when they're getting in over their head and they need extra help or need to transfer patients.
Yeah, and I think that's a big piece of this we haven't talked about is I think you develop a big network of people that can help you. They remember in residency, they always would say, never go down on the ship by yourself, fill up the boat, bring everybody in. And when somebody's having a crisis, and so you have to have your colleagues to help you. It can't just be you. And then the second thing is in your network, like our closest referral center is an hour and a half drive each direction. So it's if a person wants to drive there and back, they're going to be spending 3 hours just on the road. And you start to find these colleagues and connections of folks that you can call. And then the other challenge is, you practice where I live now for a lot of years, and on all sides of the area, you're surrounded by canyons or high elevation places where people have to drive. And sometimes you can't fly a helicopter, and even getting an ambulance out is tenuous, at least for a few hours during a big storm. But usually the phone works, and so there's been plenty of times when we've accessed a phone call to a colleague or a telecritical care type of service has helped or a teleneurology. There's some services that we can bring into the community so you really aren't 100% by yourself. To me, that kinda helps because it does sometimes feel like you are all by yourself, and you need that. You need either the reassurance or someone to look over your shoulder, or you're so busy you need another set of eyes to look at it. And so I really appreciate my colleagues. And what have you found is helpful as far as when you get in overload or in a bad weather situation?
Well, yeah, someone like you can bounce things off of them. But yeah, I think telemedicine has really been a good development to help the patient and myself sometimes allay our concerns or figure out the next step. And so I've definitely used that. And I think that telemedicine probably isn't the answer full term, like all the time, but it's a great adjunct. I think, as you've mentioned, though, it not only helps me as a doctor, but this can help patients stay in their hometown a lot of times, not only in the hospital, but full spectrum family physician also helps them not have to travel an hour and a half each way to a doctor unnecessarily when you've got an internal medicine doctor or family medicine doctor who can take care of you at home.
Yeah. But telemedicine is really useful for information and follow up with specialists, especially on the outpatient side or even in telecritical care. We found that to be pretty helpful. But sometimes I hear policymakers, both at the state level and the federal level, saying, we'll just open up telemedicine and we'll have a kiosk or something like that where patients can go get their care. But tele-delivery babies or tele-sutures and tele-broken bone doesn't really work. Like, you have to still have a physician on site that knows how to handle all this stuff. And I don't know, Lance, you and I can think of probably 100 stories, but we live near western Wyoming, which is a big OB desert. There's a large area of land that encompasses lots of little towns, and they have no obstetrics for a long time. And I remember one, we'd only tell HIPAA protected stories, but I remember one a few years ago, this poor patient who needed a C-section, and she had never decided to come in, even though we wanted her to come a little bit early. And so she went into labor, and her husband was driving, and we were on the phone, and she was in western Wyoming, and it was like almost, I think it was a 2.5 hour drive to get to our hospital, but that was really the closest place she felt like she could get obstetric services. And she was in labor and having contractions, and it's supposed to be a VBAC the next morning, but she ended up stopping at this little teeny hospital they just had one PA staffing the ER, and she did a VBAC right then and there. One of those, and the baby thankfully came out crying, and they did what they could and then put her on an ambulance and sent her to us. And I'm like, whoa, to me, that's crazy to not be able to offer obstetric services in such a broad area. And then the second thing that's crazy is in our little teeny critical access hospital, suddenly we were the referral center. That's where she was headed for the definitive care. And I think, what if we didn't do obstetrics? How far would she have to go then? What if that service just wasn't available and you have to drive another hour to get services? It's just wild.
It is, and I think you make a good point that sometimes we're looking to save money, but we might be looking to save money in the wrong places when it comes to supportive hospitals and rural health clinics and whatnot, because they serve a genuinely really important purpose for a large population of people when you take that across the entire United States.
Yeah. And you and I live in the state of Idaho, and I think every state is facing a little bit of financial constraints with like Medicaid cutbacks and things like that. But if you take full spectrum doctors out of critical access hospitals, or you water down the critical access hospitals and say we only do a limited array of services and you would need to do all these other procedures in the bigger facility, it really cripples small communities. And I worry a little bit about the safety net aspect of that being threatened by some of the current policies. And I don't know, I wondered if you had any other insights on that.
No, I think you've made a good point, though, that guess what? There's still going to be people showing up in emergency situations. And if you decide that you're shutting down obstetrics, you're even in a worse place because you have no one who really is trained to take care of that OB emergency that's showing up.
Yeah. And when it's your family, I guess that's the other thing, especially in a small town, you're at arm's length with folks because they're not necessarily you're seeing your relatives, but you're seeing people that you have other connections with and you really love them and care about them. And you really care about their outcome. And I don't know, I feel really bad if somebody doesn't get the service they need because they had to travel very far to get it and had suffered a negative consequence. So I think that there's a real value in having a full spectrum doctor that is nearby that can provide that service. And like I told you, when we had that chest tube a few years ago, I was awfully happy to hear Lance Hansen's voice walking down the hall. Like, all right, we're going to be okay because I know there's someone that is a calm, steady hand in a storm. And it's really important to have that.
The feeling is mutual. There were plenty of C-section and stat C-sections. I was like, oh, I'm glad Peter is right next door. Let's do this.
Yeah. And I think that you have to develop that. So, speaking of that, Lance, I haven't really talked about this on the podcast much, but I've told you and I've shared with podcast listeners my own experience with this tumor that I have, a solitary fibrous tumor. And so I don't know if you can celebrate a 1-year anniversary on chemotherapy. Should you call it your chemoversary? I don't know. It's kind of a terrible thing to either be happy about or sad about, but I'm doing okay. And I feel really blessed to be able to do what I do. But one of the challenges is every other week I'm on a treatment that causes me not to be able to be at my same functional level. So I've just recently announced at my facility that I'm going to stop accepting new obstetrics patients. And so it makes sense functionally, but I don't know, it kind of makes me die inside a little bit because it's something that works so hard to maintain. And I worry about my patience. Like you say, you have to take care of yourself first. And I don't know. It's just a crazy thing. I don't think unless somebody's really walked that walk or realized what an important component of your practice that is, that you could really understand how challenging that is to give up that aspect of my medicine and training.
Yeah, I identify with you. I think I just love that's a happy time, right? A lot of times people are
Right.
seeing doctors when they're worst day of their life or they're worried about something, but oftentimes pregnancy and a new baby, it doesn't get better than that. So I can identify with it. And that's a kind of a tough transition, but you're right. You got to do what's best for your health. And the fact is, all of us at some point, we do transition away from that. Very few doctors retire still having been delivering babies right up to the end just because it's so tough on your health to go all night without sleeping and then just go to work the next day.
Yeah, I'm recording this a little bit after one of those nights. I had one of those nights last night. And it's important to recognize that we can do a lot of things, but it's really important to protect ourselves. And as it pertains to the work that you're doing, Lance, you've done a lot of training with medical students, residents, and even at the high school level, students that are up and coming. And I think to the point that we need obstetrics and we need all these broad services in our community, we need to raise up future doctors or doctors in training who have this background and understanding and can carry on the torch, and we hopefully leave medicine better than we found it. So what have you found as you work with students and residents? Are there still people interested in doing rural medicine?
Yeah, I think there are. I think they just need exposure to it to see that, hey, there's lots of fulfilling things you don't see other places, in my opinion, with rural medicine. I mean, the variety and the challenge in those relationships, like I said, they just feel a lot more meaningful to me when I know them so well and their families so well, and it actually helps me to take better care of them as well. It's been a passion of mine, though, to try to develop rural physicians. I was on the admissions committee for the University of Washington for 7 years, and I saw a paucity of candidates from rural backgrounds. I saw a lot of candidates whose parents were subspecialists in Boise, Idaho, but that's not gonna serve our underserved or rural needs for the most part, most likely, and so you and I were involved in a club we started at the high school to try to introduce students to health professions, but to try to help them figure out, "Hey, I came from a poor farming background. I have no medical in any of my family. If I can do this, you can do this." And instill that confidence and also a knowledge of what needs to be done in order for that to happen. And then moving up the pipeline, I take medical students here on rural rotations. I take residents here, and it's the same thing. You just got to get exposure and to see some of the cool things you don't see other places. But also, it's good to understand what you're getting into and maybe some of the challenges, the work life balance challenges or other challenges, fewer resources that you might be dealing with. And I think if we can find those people who come from rural backgrounds, they're more likely to return to those types of work experiences. And so that's really, we need to be targeting those people when it comes to medical school admissions and to exposure in training so that it's something that they think about doing.
Absolutely. I always tell people in rural medicine, you get to do everything, but you also have to do everything. So it's the two sides of that coin. I want to transition just for a second to just the financial reality of it for a second, because one of the questions I get when people say, "Oh, you work in rural medicine, how do you feed yourself?" Because there's not that many patients, or you live in a community where the county only has as many people as there are in my high school, or something like that. Where I think the county where I practice has somewhere between 6 and 7,000 permanent residents per year. And there are people who say, that's how many people live in my little neighborhood, or how many people go to my community college, or something along those lines. And so I think people look at it and say, there's not enough business to stay in business. How could I be busy? And so I wanted to know your perspective on loan repayment and how do you stay busy, and people who look at it and say this is going to be an income deficit. What comments do you have regarding that?
Sure. Medical education is expensive. And unfortunately, I think that pushes a lot of people away from primary care in general. And also that perception that rural primary care gets paid even less. The fact is, there's lots of loan repayment programs for primary care in rural areas. A lot of hospitals will also defray some of your student loans or costs. And the fact is, the average wage is actually higher in rural areas than it is in urban areas for family medicine. I think a lot of that has to do with the workload too. You're doing more work, you're doing more procedures, which in our healthcare system are valued more. financially than just seeing someone in the clinic. But actually, as been pointed out, it's definitely financially viable, and you can do just fine. There's financially should not be a reason to not practice in rural medicine.
Yeah, I like to listen to that. To Jim Dolly on the White Coat Investor, and he's famous for saying the range of income within a specialty varies more than the range of income variability between specialties. And I think that's true. And so sometimes people say, if I wanted to be a primary care doctor in a rural area, perhaps I'd make more money. I'd be able to get my loans paid off quicker. And sometimes that really is a big incentive for people to say, I like that anyway. And it's financially advantageous. And you can get toward your financial independence type numbers a lot earlier if you get your loans paid off quickly and you have a little bit better income stream. So it really can be a big benefit that way. So I agree with just echo what you said, Lance. I would tell people that's not a reason to not choose family medicine in a rural area if that's one of your passions or your interests.
And I think also something to point out that most people probably don't know is critical access hospitals in rural areas their financials are a little bit different than other hospitals. And so they are supported differently. The government does help because there aren't as many numbers to help subsidize the care and base reimbursement on cost rather than a set number for just how much you get per gallbladder. It's more based on the cost. And so they're unlikely to lose as much money as a big hospital could. They're also less likely to make huge profits, but it makes it a little bit more stable. And so I think that there is actually some stability there. Also, if you want to look at RVU numbers, it just depends on how much staff there is in place, but I would compare my RVU numbers to anyone in the nation, and they're favorable.
Yeah. And I think that just maybe when somebody first starts, they'll have a little bit of a crescendo as they build a practice. But my experience is my practice partners and people that have come on, if you look at their practices after about 2 years in, most everybody is completely full. Most every day, every spot
Oh,
is full for the most part. And we try not to have waiting lists, that kind of stuff. But I would say most days when you come to work, there's plenty to do. And that maybe that first couple of years. But some of those things that I hear people talk about, like, why would I choose that? I'm worried about the financial part or my viability to stay in business, or I might lose out on opportunities. Boy, there's some real neat opportunities in rural areas. And I think that you and I have lived that life. We didn't just read about it. We're both 15 years or so into this experience. And so I think we can speak with a voice of experience on the Lance, as we get a little closer to our time, as you kind of have the ear of a bunch of doctors and residents and fellows and students, what are some final thoughts you would want them to know about Lance Hansen and about rural medicine in general?
no, I don't know. Nothing about me. That was nothing exciting about me, but rural medicine,
I beg to differ.
I really have found a lot of satisfaction from rural medicine. Of course, it comes with a lot of work and there's stress involved, but just the challenges, the relationships. I think there have been so many experiences that have pushed me out of my comfort zone, but I've also grown. I talking about those relationships, I'll just give you one example. There's a gentleman that came to me. He had a constellation of kind of odd symptoms, blood tests, like low white blood cell count. He was having some night sweats, a little bit of weight loss, some skin rashes. There's lots of possibilities. And I think you feel like people are family and friends because you know them more. And it's not like you can just pawn them off to a specialist and call it good. Unless, of course, that specialist gets it right. But I had an experience where I sent a guy, I was worried about some sort of cancer. I did some tests, thought he might need a bone marrow biopsy, sent him off to the oncologist. They screened it and said, oh, no, he doesn't need to be seen and he's fine. Then he's getting more and more symptoms, sent him to infectious disease after a big workup. Did I miss something that way? He's traveled a lot. They say, no, this is probably just more rheumatologic. Then he gets punted over to rheumatology, who says, oh, that rash is I'm going to send you to dermatology, who's, oh, this is classic sweet syndrome, but I'm looking at the big picture and everything, not this fragmented care. I'm like, no, I just don't think this is still the right diagnosis. And then just because you care so much about the person and you want it to be right, you dig deep. And I'm like, after studying, I think this is VEXA syndrome, which is a newer thing that I'd never heard of until I started researching all these odd constellation of things. And then you advocate for your patients and call the rheumatologist and say, hey, what do you think about this? Oh yeah, I've only had one other person who's ever had this. But nevertheless, he gets tested for the gene mutation. That's what he has. But it's just an example of, and sometimes in a bigger place, it would be easy just to send them off and not worry about it. And there's not really any sort of connection. And in our case, oftentimes we see these people at church, we know their families, we know them as fathers and as all the different responsibilities or hats they wear, we know more personally. And so it's more meaningful, I think, that when you have those triumphs, and it's also more difficult when you have heartache. You and I have had many times where we have people that we know and care about deeply and things don't go well. And so I think emotionally it can be swings both ways, more to the extreme than it would be otherwise.
Yep, the highest highs and the lowest lows for sure. Medicine is such a unique job. It's really a gift to be a physician. And I still think it's the greatest profession in the world. There's nothing quite like it. And I'm thankful to be a part of it. And Lance, as we tie up here, I just want to say thank you for what you do for your community. I know your heart's in it and you have a strong desire to leave medicine even better than you found it and to continue to serve that community you're in. And if people wanted to follow along with Lance Hansen or contact you if they had any questions, how would you recommend for them to contact you?
I have a Facebook and a LinkedIn profile, so that might be the easiest way.
Okay, perfect. We'll put that in the show notes. And Lance, thanks again for taking the time to do this, and appreciate what you're doing, and keep in touch.
Thanks. Appreciate it, Peter. Thanks for having me.
Thanks for tuning into the Doctors Making a Difference podcast. And thank you for what you do to help your patients and your community. Your work truly helps so many people. We produce this content to help you have the tools you need to stay in medicine and to highlight the amazing work being done by physicians around the world. Please note that while I am a physician, and many of the guests on this program are also physicians or other professionals, the discussions on this podcast do not represent my employer or any professional organizations to which I belong. This podcast is for your information and entertainment only, and should not be taken as professional advice. You should seek appropriate professional advice pertaining to your own situation. Please check out more of our content on our website, doctorsmakingadifference.com. Also, please follow, like, or subscribe on your podcast player or YouTube channel, and give us a 5-star rating. It really helps to spread the message. Finally, if you'd like to be a guest on the podcast, or if you'd like to nominate someone else to be a guest, please visit the website or email admin@doctorsmakingadifference.com. See you next time.